And so it gives me enormous pleasure now to welcome Professor Salles. Professor Salles Professor Salles was my boss when I went over to work in France for a year. Packed my family and head off to work in Lyon. He's the head of the hematology department there in Lyon, where he has established one of the world's leading clinical research units, and he and his fellow colleagues in Lyon have led the French lymphoma clinical trials group called LISA, and it's just an absolute pleasure to have Gilles over here in Australia talking to all of us. Thank you very much.
Good morning. Judith gave me another title, which was Lymphoma in the 21st Century, which was not the easiest talk. And because I understood that there may be also some people less familiar with lymphoma, I will start rapidly with some very basic background about lymphoma, and then we'll move on to more recent progress. Maybe that's very common knowledge to you, but what is lymphoma basically? Basically, lymphoma is a cancer that is developed from cells that circulate in our bodies that are called lymphocytes. These are cells which are part of the white blood cells or leukocytes that are assessed on blood tests. What we need to understand, all of us... sorry, yes. Sorry, I didn't. Is that these cells are present in what we call the lymphoid organs, which involves, first of all, the lymph nodes, and we'll come to that in a minute, but also spleen, tonsils, bone marrow, blood, but also most of the organs of our body, because this is part of the immune response, the response against pathogen microbes that come to us, and all the superficial covers the skin, but also the gastrointestinal tract, the lung, the mucosa of the mouth, of the eyes, and so on, do have lymphocytes. So this explains why we can have lymphoma in any part of the body. And finally, because these cells are here to defend ourselves against these pathogens, they have to recirculate in the body. And that's the reason it's a blood disease and blood cancer. And that's the reason also we don't talk about metastasis in this disease, because by definition we do feel that this is going to be a disseminated disease. So this scheme, which is, I have tried to translate in French, from French to English, gives you small hints of tonsil, lymph nodes, which can be in many parts of the body, obviously the neck, the axillary regions, the groin, but also in depth in the abdomen or thorax. Spleen, thymus, tonsils, all can be involved by lymphoma. Why do lymphoma occur? Well, I mean, it's a very complex question, and I will try to help you to understand a little bit about that. Lymphocytes are very specialized or very complex cells. They are born in the bone marrow, that's what we think, and they go to different steps of what we call differentiation, what we may call education, and it goes from immature B cell to what we call naive B cell, and then they come into these lymph nodes, and they have contact with different cells, and they can undergo different processes. Either they die or they proliferate. It's in French, sorry about that, but I'm sure you can understand. And that's for B cells. Some of them will produce the antibodies that defend ourselves against pathogens, and some of them will sit for ages, being the substrate of immune memory. Vaccine take advantage of this phenomenon of immune memory. Well, this is a very complex process, and as any complex process, it takes part into this cell, and during the normal education of this cell, we have genes in the cells that undergo rearrangement and mutations, And I will say that lymphocytes are the only cells in the body that are able to do that without dying. In any cells, when you damage the genetic material, DNA, the cell undergo apoptosis and die. Here, because of complex regulatory pathway, and because we need to diversify our defense against pathogens, all these phenomena that will usually lead to death are repressed, and these cells can accumulate damages. Well, sometimes, unfortunately, these damages damage crucial system in the cell that may lead to a malignant cell. So, do we know more about the causes of lymphoma? Well, first of all, as I said, this is a disease derived from cells which are very specific, very complex, and most of the lymphoma occur by what I will call, unfortunately, natural accidents. This is just a mutation that occurred in a place where we should not have occurred, but that's unfortunately life, and that's probably the most frequent cause. However, you probably know and have heard, and we always feel like that not everybody will develop lymphoma. And there are probably some patients, some individuals, which are more prone to develop lymphoma. What do we know about that? And I will come to that later on in my talk. There is probably a genetic background which may explain some susceptibility of lymphoma. And I should say, and I should confess, that 20, 25 years ago, when I have met a patient who asked me whether somebody from his family will have an increased risk to develop lymphoma, 20, 25 years ago, I would have said no. And today I have to say yes. It's a very limited risk. It's a very low risk, but there is some increased risk in relatives of a patient. We don't have way to diagnose very early lymphoma before it develops, but there is a genetic background in this disease. It's different from what I will call genetic transmissions that we do know in breast cancer or colon cancer, where we have particular genes that are mutated, and I will discuss that later. There are, however, also probably some lifestyle or environmental factors that may play some role, probably small. There is an abundant literature on this topic. I don't want to summarize everything, some occupations, some work, different geographic regions and things like that. We probably can't do much about that. There is a recent publication by what is called the Interlymph Consortium, which is a consortium that involves and groups all epidemiologists through the world. I think there are Australian colleagues also in this consortium. And they have reviewed data on 19,000 patients with all questionnaires about their lifestyle and environment and things like that. And there is one thing which I found quite interesting, is that there is an increased risk of lymphoma in patients that were overweight as young adults. And I found this is interesting because we can prevent that. And that's probably one interesting new knowledge we have about the very simple factors that may lead to increased risk to develop lymphoma. Finally, there are certain medical conditions which are associated with an increased risk of lymphoma, some autoimmune disease, some viral infections, some bacterial infections, and unfortunately patients receiving immunosuppressive drugs after organ transplant specifically, or eventually some other diseases. Well, I will get the right way. How is lymphoma diagnosed? Well, that's very easy, and I will go to that very quickly. Usually the most frequent way to diagnose lymphoma is an enlarged lymph nodes that can sit in any part of the body. If it's superficial, it's easy. If the lymph nodes sit in depth of the body, well, signs and symptoms are usually very non-specific and occur late. If it's in the thorax, you may have some cough, shortness of breath, and things like that, but this is very specific. In the abdomen, very common sign of discomfort in the belly, and that's sometimes difficult, which usually led to the fact that we diagnose this kind of lymphoma with much larger lymph nodes than the superficial ones. We have also lymphomas that develop in any place in the body. We have symptoms that are related to the specific organs involved in lymphoma. Can be skin lymphoma, for instance, with some lesions on the skin. and also some general symptoms such as weight loss, unexplained fever, night sweat, or pruritus. Well, sometimes also it's a fortuitous discovery by a patient undergoing ultrasound examination for another reason, or CT scan examination, or sometimes on a blood test. I think some of you have gone through that, but usually as doctors, a general practitioner will try to rule out any other disease that also involve lymph node enlargement. And if there is doubt or suspicion, you will usually come to a specialist, oncologist, or hematologist who will perform a diagnostic biopsy. Well, usually, except a few exceptions when there is blood involvement or organ involvement or only bone marrow involvement, but there are very specific exceptions, lymphoma diagnosis requires a lymph node biopsy. And I think that's very important to understand, because we'll make more and more progress in the future in trying to understand better the disease, characterize the disease, but also do some additional tests that will help to choose treatment. And for this reason, we do need biopsy, which is better done, I will say, and that's my personal opinion, and maybe there are some discussion with other colleagues, as an excisional biopsy rather than a biopsy with a big needle. Because these provide more material, and in the future we'll have more tests to decipher lymphoma. And expert pathologists sometimes need additional tests. The most common one, immunohistochemistry, where you put specific antibodies recognizing some molecules, proteins on the surface of the cells, and this helps to classify lymphoma or to identify even therapeutic targets. But there are many other ways, and we'll discuss it later. Well, I think this was touched already. There are several lymphomas. Hodgkin lymphomas that we called in the past Hodgkin disease. Now we recognize it's part of the lymphoma with some major subtype. And non-Hodgkin lymphoma. The most common are B-cell lymphoma, and it represents almost 85% of all lymphoma. I have said there are 15 subtypes. Well, if we go in detail, there are 35 subtypes. But let's keep it simple. For T-cell lymphoma, it's the same. I said 8 to 10. I mean, my colleagues experts in this field will say probably more. But let's keep it simple. But you realize that the most common lymphoma are B-cell lymphoma, especially diffuse large B-cell and follicular lymphoma in particular. We have many tools to treat lymphoma. The usual tool is chemotherapy. Because it's a disseminated disease, again, cells do circulate in the body. And we have cured the first patient with lymphoma using chemotherapy. It cures many patients. These are well-known drugs. They have substantial side effects, but because we use these drugs for many, many years, they are well-known, they are predictable. And I think talking with your physician will help for that. We do use transplant from time to time in specific patients with specific causes of the disease, patients at time of relapse or with very aggressive form of lymphomas. There is autologous or allogeneic transplant. I will not come into detail for that. We can come to that for the question and answer part of this meeting. Radiation therapy is still used in lymphoma for some low-grade lymphoma, for some aggressive lymphoma, for Hodgkin lymphoma. It's an old way to treat patients, but it has improved considerably in recent years with a more focused way to deliver radiation therapy to more specific place, only to the areas that are involved by the disease. And the modern radiation therapy techniques do not result in long-term side effects or in much fewer side effects than the old radiation therapy techniques that were used 20 to 30 years ago. One breakthrough in the treatment of lymphoma was immunotherapy, and probably you have heard, and most of you are aware, that in B-cell lymphoma, the antibody against the CD20 antigen, which is called rituximab, has really helped us to make a really big step in curing more patients or in allowing some patients with some indolent disease to live for a longer period and almost experience a normal life. And we'll have some new targeted therapies. I think Judith will comment on clinical trials, but definitely how we use these agents depends on the information and the scientific information we have, which is derived from large studies, which we call phase 3 studies. These phase 3 clinical studies really allow to determine if a new treatment is more efficient than the standard treatment. And that's the way we have to go, and we have to evaluate the risk-benefit of any new strategy. We can evaluate new drugs, but we can also evaluate sometimes old drugs. We should evaluate combination of agents, but we can also evaluate a treatment plan, a strategy. That's important, for instance, in Hodgkin lymphoma, where we have evaluated recently the way to use radiation therapy, the way to diminish the number of courses of chemotherapy delivered to patients, and adopt a strategy. And this was done in several trials, and I think Australia was particularly involved with the so-called RAPID trial, if I recall well. Not RAPID, RATREL trial, sorry. These phase 3 trials need a comparison. And as physicians, we are biased. Because this patient is younger, may tolerate this treatment better. Because this patient is older, well, let's try to use the treatment with less side effect. Or because we feel this patient doesn't like to have hair loss. Nobody likes that, actually. So let's use this treatment instead of that. So we are always biased. And the only way to compare scientifically, rationally, two treatments is to do a blind comparison with random assessment to patients from one treatment to the other. This involves large phase 3 clinical trials. Large number of patients are involved. And I think we have to keep in mind that this costs a lot of money, and it's more and more difficult for people like us in the academic field to conduct, design, and analyze this lymphoma, and that we should fight for still in the future. And final word on this general background, PET-CT. I think everybody is familiar or start to be familiar with this new technique of evaluation of the disease, which is the metabolic activity of the disease, the uptake of glucose by any malignant cells, which allows us to look at the lymph nodes that are involved. These are old PET-CT, but you see all the lymph nodes that were involved in the left before treatment, and see that they have disappeared after treatment. We have made a lot of progress with that, and I will come to that. So, what is new in the 21st century? Well, as you know, cancer research usually starts from the lab. And what happens in the lab, or what happened recently in the lab? Why do some patients develop lymphoma, and why some have, well, we don't know what, but more unfavorable disease? This cartoon describes a few ways we work and try to identify in the genetic background of individuals little variations of gene sequences. We call those SNPs. And there have been a lot of work being done recently. Well, again, let's come back to the genetic predisposition of cancer. There are some cancers that have a high genetic background, and in which a few genes which are mutated do influence the risk of lymphoma. Again, this is breast cancer, this is colon cancer, and a few other subtypes. These genes, where they are mutated, the risk to develop the cancer is high. But in fact, what is important and has been really investigated right now is that we all are different. We have different colors of hair, we have different eyes colors, and things like that. These small variations by frequent variants may influence the likelihood of having a disease. And this is true for these common variants that are general in the population, and that may potentially explain some of the background to the disease. Well, last year there were 3 major papers published in the scientific literature that identify a couple of these genetic backgrounds, variants, which we call SNPs, which identify what we call susceptibility loci for diffuse large B-cell lymphoma. This is one of the papers in which our group was involved for diffuse large B-cell lymphoma. And yes, this just represents, these little points represents the locations in our genes which are associated with increased risk, and those are this region and genes. Well, this is basic science, but what are the implications? Well, the first implication is allowed us to have a better understanding on the biology of the disease. There are common links, common traits between different lymphoma subtypes, also between different diseases, between different cancer. And this points us to the importance of some region of some genes. For instance, it's a surprise, or it's not, to see that this region is involved with variation in many cancers. Initially, it was identified in lymphoma, MYC, but in many cancers, this region has some specific traits, and this is true for prostate cancer, for breast cancer, but also for lymphoma. So there are common grounds to the biology of different cancers. The second question, which we felt is also very important and interesting, is this variant represents a small increased risk to develop lymphoma, but they may also represent a small increased risk to have aggressive lymphoma. And that's pattern of work that is going right now with several groups in the world to try to identify if these variants do influence patient outcome. Is that very complicated? Well, actually, it's not very complicated, because to investigate these variants, just need a blood test right now. So this is probably one of the ways precision medicine will go in the next future. We have analyzed the tumors. Before that, this was individual, the host of the tumor. We have analyzed the tumors. The first way we analyzed the tumor many years ago was to look at chromosomes. And we have more sophisticated techniques to look at those. And we have had more and more sophisticated techniques to look at genes that are expressed in lymphoma. And we do know now for a couple of years that there are some patterns of genes that are expressed in lymphoma that are associated with different outcomes. Well, is that important for treatment? Yes, it is. Because this subclassification of lymphoma may potentially help in the near future or even today to identify some patients that may respond better to some given therapy. And there are actually in the world, and probably in Australia too, at least 2 or 3 trials that actually are based on this identification of subtypes which were defined by this kind of analysis that were developed 10 years ago. And patients in this room too. It's still a little bit complex because the way to reproduce this result from the basic science for very specialized lab in daily practice in every center caring for patients with lymphoma is not already well assessed, but there are a couple of different techniques. A couple of companies are patenting those. That makes the story a little bit more complex also. But I think that many centers will be able to do that and to identify those patients. A few words about monoclonal antibodies, immunotherapy, and other targeted therapies. Well, we have learned that this famous CD20 antigen that is expressed on B cell in almost all B cell lymphomas is recognized by the antibody rituximab, and potentially the killer cells come and will kill the cell that is covered by this antibody. Well, that's what we think happens. In fact, we are not sure how it happens. And we are not sure about the different mechanisms that are involved in this process. And there is a large part of work and biology being done trying to understand how this mechanism functions really, not only in vitro, in the test tube, in the lab, not only in animals, but also in humans. Because if we do understand well this field, then we'll be able to make progress and to improve antibody. Because if this works, then everybody should be cured. So it doesn't work exactly how we hope. Does that translate in changes? Yes, that does translate already in changes. There is, based on that, a rational design of new antibodies. I mentioned these antibodies. That's one example. There are several others. This is an antibody that has been developed to have improved B-cell killing. And it has improved B-cell killing because it does recognize a different portion of the CD20 antigens, and by recognizing a different portion, it better kills the cells than rituximab. It mobilizes also better these famous killer cells. It attracts them better and activates them better in order to kill them. This drug is in development, has already shown to be superior to rituximab in patients with a different but very close disease, which is chronic lymphocytic leukemia. And it's being evaluated in clinical trials in lymphoma, and in 1 or 2 years, we probably will have some results. I actually heard some results in patients in relapse. And I do hope, because there is very strong rationale behind that this drug will help us to make progress. But understanding the way this antibody works will help to continue to improve them and to make more powerful drugs. There is one recent field of interest, especially in Hodgkin lymphoma, that had come through. This field is the fact that, unfortunately, and again, our lymphocytes or immune cells are here to fight against pathogens, but are also here to fight against cancer cells. Well, the process, unfortunately, doesn't work. If it was working, we'll never develop cancer. Well, scientists have started to understand the process by which cancer cells actually deliver signals to the lymphocytes, tell them, don't kill, and they basically exhaust the lymphocytes. So this lymphocyte exhaustion has been analyzed by scientists, and a couple of molecules, which are shown here, which are called PD-1 and PD-L1, PD-L2, appear to play a very important role in managing these interactions. And obviously, this had led to development of drugs. That's one of them. There are several of them, which actually block this exhaustion. What we heard recently, actually 2 or 3 months ago at ASH, during the American Society of Hematology, is that this agent do work in patients that had failed other therapy in Hodgkin disease. This is on a very low number of patients. These are very preliminary data on actually 23 patients in one trial, 15 in the other one. So it's very premature. These drugs are not without adverse effects. They have also adverse effects. But clearly, it brings a lot of hope in moving forward with a new way to treat some of these B-cell malignancy and, on the first step, Hodgkin lymphoma. So finally, targeted therapies. Well, I have many cartoons. That's just one of them. What happens? All cells, and normal cells, but also malignant cells, depends on signals that are delivered to the cells. And these signals go to a couple of molecules, which are summarized here, which sits on the surface and delivers pathway which tells the cell to proliferate and to grow and so on. And that's part of the dysregulation of this pathway makes the cells malignant. Many of the mutations actually influence this pathway. So what happens is that many drugs have been developed right now to try to block some of this pathway. And that's what we call targeted therapies. They are developed, again, in many fields of oncology, and I will try to show you 1 or 2 examples in lymphoma. So that's what happens in the lab. What happens in the patient? First thing is that we have improved the way to analyze lymphoma using PET-CT. And again, PET has helped us to assess more carefully the activity of our drugs. We have standardized the scales of evaluation of PET, and that was a work by many specialists in the world. Precise time of evaluation of using PET. It has helped to evaluate patient prognosis, and it may potentially, in some instances, replace traditional PET-CT. Well, this is done by some international collaborations, and Gilles Trotman here had played an important role here, as you see on this paper that was published earlier this year. This is an international collaboration between, sorry, there was not Germany this time, but French, Italy, and Australia. Next time, Germany will be here. So I think that's very important, and we do continue to assess and try to improve what we can assess with PET-CT. And another new way will be not only at this time we assess glucose uptake and eventually measure glucose uptake, but there are new tools being developed that will help to assess what we call tumor volumes or even metabolic tumor volumes. This is an example of calculation of this glucose uptake made on the body, and these are some survival curves. You are, I think, understanding what it means. I mean, there are patients surviving longer than the other ones, which are derived by the measurement of tumor volumes that are, again, very new data that we presented at our meetings 2 weeks ago, indicating that this way assess really the involvement of lymphoma in the body and the amount of lymphoma cells patients have in their body. So this needs a lot of physics, a lot of calculations, a lot of standardization of the machines, but we have made many progress with standard PET-CT, and I'm sure that this metabolic tumor volume will also help us to continue to improve the way we assess the burden of disease at onset of the disease, but also the response to therapy. And I know also we are doing a project also on follicular lymphoma that Judith is leading in this field. A word on immunotherapy. I already touched that very rapidly. So do we have new antibodies? Again, the first antibodies were anti-CD20 antibodies, rituximab. There have been a couple of others. Very few of them have demonstrated a real benefit. And many other naked antibodies against many different proteins, antigens expressed at the surface of tumor cells were developed. Very few of them, if any, have made their way to the clinics and to the progress. We don't know why. I mean, it's a general principle. It should work for others. It worked very well for CD20. There are still clinical trials with CD37 at least, CD19, a couple of others, but this naked antibody haven't had to make major clinical progress right now. There is a new field which is quite interesting, which we call base-specific antibodies. These are antibodies recognizing the tumor cells, but helping to attract and activate the T cells, the immune cells that will fight against them. These drugs have been developed in acute lymphoblastic leukemia, has been approved in the US, Europe. I don't know about Australia, probably will be approved once. I hope so. And there are development of these kind of drugs also in lymphoma. Actually, the first drug was developed in Germany, this drug blinatumomab. But there are other drugs being developed, and that brings a lot of hope. It's a little bit complex. There are some side effects also which are quite peculiar, but it's a new way and new drugs being developed. Sorry about this slide that get confused during the plane, but this is radioimmunotherapy. Well, 15 years ago, we had a lot of hope in that. This was a way we put an isotope that will kill the tumor cells close to an antibody, and this will kill the cells. And there were a couple of those drugs being developed, and for diverse reasons, which we may discuss later, these drugs have not made their real way to general practice or to general clinics. Some are approved in Europe. I don't think they are approved in Australia. 2 of them were approved in the US, but actually they are barely used on very few indications. I don't know if Professor Rummel used them a lot. I think one is marketed in France. We haven't used it for 5 years, at least in the department, clearly meaning that we don't feel that these drugs help a lot. However, the concept is still true, and there are some reasons why maybe these drugs were not the optimal one, because rituximab was here, and I think that is still a field that will be developed and maybe will help once. Another very smart way to use antibodies is to deliver chemotherapy. And instead of using cytotoxic agents that kill the cell directly by infusing them in the blood, they are linked to an antibody, and they will be released only at the site of the tumors. So the first one of this antibody that has been approved in the US, in Europe, and I think I heard is under scrutiny here in this country, is called brentuximab vedotin at Cetris. And it's a drug that has been developed in Hodgkin lymphoma and in some very specific subtypes of non-Hodgkin lymphoma called anaplastic large cell lymphoma. So you see the drug, the cytostatic drug here, which is a very complex name, MMAE, basically, is linked to the antibody. And when the antibody approaches the cell is recognized by the expression of this antigen. The antibody penetrates the cell, and within the cell, and only within the cell, the drug is released. So we do hope that this is a smart way to deliver chemotherapy, which will lead to increased efficacy and lower toxicity. I should say this is a theory. In fact, it's not exactly like that. Unfortunately, there are probably some free drugs being released or other side effects, and we do encounter with all these new agents, this antibody drug conjugate or immunotoxin, some side effects too. And these drugs have been approved because of a very high response rate. There are a couple of other immunotoxins being developed. This is a couple of examples by different companies in the world. I'm not sure how well they will make their way to the clinic. There are some encouraging preliminary results. There are some clinical trials still running. I have seen patients really getting benefit, but not many and not very prolonged benefit. And again, we do encounter some toxicity. So it's scientifically, rationally, it's a good way. You know, instead of infusing chemo, we target chemo. But it may not work exactly how we like. Well, sorry for this cartoon, which is a little bit complex, which actually acknowledges the fact that there are something we don't understand. When it's too complex, that means even us, we don't understand how it works. This is this old family of drugs, which are called IMiDs, which is actually a patented brand, which are the analogs of the old drug thalidomide, and the current drug are lenalidomide or pomalidomide, which are drugs that are being developed and approved in multiple myeloma, which is another hematological cancer. These drugs are being investigated in lymphoma because they may potentially activate and improve the efficacy of rituximab or other antibodies. Our colleagues in the United States at the MD Anderson have actually made a clinical trial where they combined rituximab and lenalidomide for a regimen that was called R-square, and which was published very recently in Lancet Oncology, and have shown that this combination of lenalidomide and rituximab actually led to a very high response rate in follicular lymphoma. That was the ground of a clinical trial called Relevance, and I heard that people participating to the trial are in this room, and which actually compared classical chemo to this combination of R-square non-chemo approach. Well, we don't have the results. 1,000 patients participated to the trial worldwide, thanks to those that participated in Australia. Everybody makes a step and helps make a step. What I should say about that is that there is no classical cytotoxic chemotherapeutic agent. But it's not because that is what we call chemo-free that it is toxic-free. These new agents, these new drugs, which are not chemo, also do deliver some very specific toxicities. And we should be continuing to scrutinize the clinical trials to evaluate well the risk-benefit of these drugs. But lenalidomide and others are well investigated over there. I will go through that and come back to finish with these slides very quickly. These are against drugs, and I thought I had, a cartoon, again that target the signaling into the cell. There are basically two drugs that are approved in, again, US, Europe, and I think are being examined in, being examined here also in Australia, which are blocking here one protein which is called BTK, and other proteins here which are called PI3 kinase. So drugs are called ibrutinib here and idelalisib here. They have shown to be active in chronic lymphocytic leukemia and in some subset of lymphoma. BTK inhibitors, ibrutinib, have been shown to be active in patients with mantle cell lymphoma. And it's an oral drug. It has some side effects, including an increased risk of bleeding, but in general it's well tolerated, I should say. Ibrutinib is the first generation of these drugs. There are a couple of new drugs, new BTK inhibitors being developed. we do feel these drugs are useful. We do feel these drugs can be used either as single agent in some subset of lymphoma or in combination with chemo in other subsets. To adjust exactly what will be the future role of this drug is, I think, still to be defined, keeping in mind that these drugs works as breaks into a signaling pathway, but they don't really kill the tumor cells. And that may be one disadvantage or one limitation of these drugs. Because, yes, the cancer is maintained at a lower level, but unfortunately we do know that cancer cells usually escape to these breaks because of new mutations or because they find a way to escape, and they will probably regrow. So I think these drugs are very useful at the time in some particular patients' population. I should make a little caution about the spread of these drugs, which may not finally help completely to cure patients, which is still our goal, I think, for all of us. Well, I will finish with 2 slides. The first one is this one. You have seen already complex cartoons. Well, behind this cartoon is an even more complex cartoon. When we touch something into the cell, we touch at many things. And before we understand everything, there is still a way to go. So that's one word of caution about targeted therapies. Yes, they bring some hope. Yes, they will help us to manage a couple of patients, but it's very complex. And we will have probably to combine drugs. And some of the combinations that have been tried, for instance, one inhibitory drug called SYK inhibitor and the PI3 kinase drug, the trial was interrupted because of toxicities, unexpected toxicities. So it's sometimes very difficult to combine drugs that are supposed to be specific, but this led to unexpected side effects. Oncologists already know that in their field, and we learn that. So it takes time to manage this interaction and these interactions and what's the right target and how to develop that. So I think there is still some hope, and to finish with that, I managed to have a cartoon. To start with this sentence, it's in French. Probably some of you are familiar with this cartoonist, which is Antoine de Saint-Exupéry. And we are fighting, we are moving forward, and maybe we'll succeed, but if we don't get there right now, at least we move towards. I thank you for your attention, and I was a little bit long, but I'm happy to answer any questions.
Thank you. Just wondering about the role of alternative therapies to use of supplements, marijuana.
Perhaps you'd like to give the short answer to that, Gilles, now, and then the long answer during the Q&A session.
Short answer. I think when patients have to fight a disease, I will always think that it's normal that you try to get the best and to get the help from many places. As mentioned by Judith, usual drugs are drugs that are approved to go through a very rigorous pattern of evaluation. This is not necessarily the case for some of the supplements and some of these alternative therapies. Why is that? I think that's a complex question and needs to be debated. My answer to the patient I care for when they ask me this question is very simple. If they feel this helps, and if in France and in Europe, homeopathy drugs are very common. I don't feel it harms, as long as it doesn't harm their budget. If it starts to harm their budget, then I'm worried. Because if something expensive or that is sold at an expensive price will be very useful, we'll probably already know it. So that's my very plain answer to your question. Yes, there are alternative therapies. Yes, maybe some patients feel better because they take some agents that help them to tolerate classical chemo and so on, and if it helps them, that's fine, even if it's not rigorously evaluated. But as long as it doesn't harm them, as long as we do know what they take, and as long as there is not somebody behind that may take profit on selling these drugs.
I think also, Gilles, it's important to think what drives people to take alternative therapies, and it's often, the desire to be doing something yourself in addition to what your doctor is doing. And, that's where, isn't it, walking well, eating well are just absolutely crucial to helping your body deal with the therapies of the lymphoma.
Is that good?
Very well.
You spoke about PET-CT and using that to make better treatment choices. Could you comment on the risk-benefit of the high radiation doses?
Well, at the present time, we do know that PET-CT delivers more radiation than classical CT or with attenuated radiation. And the long-term effects of these low-dose radiations are not well known. We have to admit that. I still feel we are in conditions which is a patient that has developed a disease. So these are not screening tools. These are tools which are aimed to help us to monitor a disease and to monitor the efficiency of a disease. In a patient that receives a first-line treatment for Hodgkin lymphoma or non-Hodgkin lymphoma, I feel that patients will usually undergo 2, 3, maybe 4 eventually PET-CT, but not more in the first-line treatment. And I think even if this is an increased dose of radiation, as compared to all the advantages in monitoring the disease, in, for instance, preventing the use of classical radiation therapy, because that's what we have trying to evaluate in Hodgkin disease, for instance, I am quite convinced that the risk-benefit ratio sits in the side of using PET-CT. Where PET-CT should not be used is to survey patients after they have been treated. And that's very important. And if I have one few minutes on that, even CT should be less and less used in these patients. There are publications coming in the field of Hodgkin lymphoma, in diffuse large B-cell lymphoma, showing that surveillance CT scan are useless. So we should use imaging techniques, even if they irradiate a little bit, to assess the efficacy of the treatment, to adjust in each individual patient the treatment. But when the goal has been achieved, which is the disappearance of the disease, which will probably rely on clinics to evaluate patients. Well, if the disease recurs, unfortunately we will have to reuse imaging. But when the disease recurs, we all do know that it's more and more important to adjust therapy, to evaluate new agents, and we'll have to go through this kind of imaging again. But in the first-line treatment, I think 2 or 3 PET-CT really brings a benefit in the way we have helped to personalize treatment as compared to older techniques.
And can I say that we're working very hard to get PET-CT scanning on the Medicare benefit schedule for all glucose-avid lymphomas, because it's not actually available in particular for follicular lymphoma yet. Okay. Gilles, I think it's France 3, Germany 0. That was absolutely superb. And we're most grateful to you, Professor Salles, for that.